we were treating acute myeloid leukemia with 7 and 3 back in 1977.
Yes.
In 2019, we're still doing the same.
Yes.
What is the best way forward to change it by 2029?
That's a great question, and wish I had a perfect answer. We have always hoped that understanding the disease better, understanding the exact reasons that a normal hematopoietic stem cell turns into a leukemia stem cell will inform how we design new therapies. I think there's been an enormous amount of progress made in understanding some of that biology and certainly the genetics of what happens as cells become malignant. I think an enormous challenge is that those malignant cells are so similar biologically to their normal counterparts that developing selective agents that kill the cancerous cells and not the normal ones has been much more challenging than I think people had even anticipated. I think another humbling aspect to it is that the newest therapies that are really showing benefit, like combining hypomethylating agents with venetoclax, wasn't a terribly informed decision either, that they are relatively nonspecific drugs that actually work quite well, just as we don't totally understand why chemotherapy works so well. So at least that's a sign of progress, but not necessarily one that was fully informed by our new molecular understanding. That said, there are opportunities. FLT3 inhibitors and other drugs are showing promise in the clinic, so I think we do have evidence that understanding those molecular abnormalities can lead to new therapies. We definitely have ways of improving outcomes with bone marrow transplantation and identifying the patients who are most likely to benefit. So I think there are ways now that we can stratify patients and identify those who will respond better to new therapies. And then ultimately, as we develop a range of novel therapies, combining them is likely to be what is most effective. And in cancer in general and in leukemia in particular, combination therapies have been particularly effective. And in a disease as aggressive as leukemia or MDS, we need to probably hit the cancer cells in multiple different ways. So hopefully, as we build the armamentarium of therapies with some efficacy, we can start to combine them in clever ways that really leads to meaningful improvements.
Thank you. Second question. 3.5 million papers on cancer. 135,000 in 2017 alone.
Yeah.
Why is there such a staggering disconnect?
Yeah.
Between improving better insights into the biology of cancer and translating that into improved therapy?
Yeah, that's a great question. The numbers are staggering that you note. I think to one degree it actually highlights perhaps the misaligned incentives in some aspects of cancer research, where many investigators are focused on publications rather than improved therapies, or just that there are now journals that are so bent on publication and careers that are dependent on publication that there are just such a staggering number of publications that at some level become completely disconnected from as a marker of progress. I think the other answer just is that identifying ways to selectively kill cancer cells is an extremely challenging problem, and that developing new drugs is an extremely powerful and expensive endeavor. I would say that the rate of improvement in cancer therapies, the rate of development of novel therapies, is accelerating. And while there is still a disconnect in terms of publication numbers, the amount of progress is unmistakable at this stage, and often comes from the least expected places. And so the fact that there is a broad range of cancer research going on, I think, is wonderful, because the least expected areas are often the ones that are the biggest breakthroughs. That for many, many years, people thought immunotherapy was such a waste of time, was never going to work, and the small band of people that stuck to it and knew that if they stuck to it that it would eventually yield fruit have proved themselves right and been a transformative development in cancer therapy. So it's great that there is such a broad swath of cancer research, even if the publication numbers aren't a great proxy for that. And my hope would be that somewhere mixed in there is going to be great opportunities, and that we'll be smart enough to recognize those and develop them into therapies.
Third question, the fact that children respond to the same treatment better than adults seems to suggest that the biology of cancer is different.
Mm-hmm.
Of course, the host is different.
Mm-hmm.
So my question is, since most cancers affect the elderly,
Mm-hmm.
that means even having great therapy may not matter because the host is decrepit.
Right.
Your solution?
Such an interesting question. So biologically, it's certainly true. The pediatric cancers have different genetics, different drivers than adult cancers, so they are a different disease. And it's absolutely true that children respond to chemotherapy in a different way from adults and can handle more chemotherapy, tolerate it better, recover faster. So no question that both the disease and the host are different between children and adults. I think that's probably most marked with cytotoxic chemotherapy that is very toxic, and the ability of the host to handle that therapy is age dependent. I don't know if that will be true for all new therapies. So we mentioned hypomethylating agents plus venetoclax was developed in some ways for the patients who couldn't tolerate the chemotherapy, but maybe it's going to work as well or better than chemotherapy independent of age in many circumstances. So hopefully some of the more targeted therapies that have less broad toxicities won't have quite as severe an age dependence in terms of the tolerability. Other therapies like stem cell transplantation still do have a marked difference in outcomes with age, and so that will always remain a problem. But there too, our ability to manage infections, manage complications has allowed us to constantly increase the upper age of tolerability of stem cell transplantation. So both are going to have to be in the understanding the biology of cancers in the elderly, as well as improving therapies that are more tolerable. Both need to be major focuses of research, and I'm hopeful that we'd be able to make progress on both of those.
Excellent. The fourth question is, you have great knowledge and experience in the field now. If you were given limitless resources, that's
Mm-hmm.
money is not the problem.
Mm-hmm.
What is your solution to finding the cure for cancer?
That's a great question. You know, I tend to always think that I won't choose well enough, and I am a huge proponent in science in general of spreading the wealth and allowing the marketplace of ideas and the entrepreneurial spirit of large numbers of investigators to follow the leads wherever they may lead, and 1,000 investigators following fascinating leads may do better than giving 1,000 times more money to one person or to a small number of people. So I think the ability to support basic research very broadly to smart people and motivated people that are wanting to make a difference. Maybe that research is totally focused on cancer. Maybe that research is more basic and isn't immediately focused on cancer, but one day could be transformative. I think those insights are likely to be the most transformative. There have been certainly big science projects that have transformed our understanding of cancer, like the cancer genome sequencing studies that have really unveiled the genetic basis of cancer. And so those were expensive, large, coordinated studies that wouldn't have worked by individual investigators, and there are many more of those to be done. One at the moment is really understanding pre-malignancies and the very first steps of progression, understanding the cellular heterogeneity of cancer at a single cell level, understanding the microenvironment of cancer, understanding the immune system. Some of those can be funded in a very large way and are absolutely meritorious. But I also like the idea of spreading funding across a larger number of individuals who have somewhat crazy ideas and maybe just below the funding line now, because often funding agencies are conservative and they want to fund what's trendy and what everybody else is doing, but allowing some really innovative ideas to get funded is I think in the long run what has enormous potential. So that type of support I love. And then ultimately, if we want to cure cancer and improve the outcomes of patients with cancer, we need to develop new therapies. That is an extremely expensive endeavor, is in the hands of drug companies, which can work very well, but there are circumstances where a rare tumor or childhood tumor may not make business sense for a drug company, and so having funding for drug discovery efforts outside of the traditional private sector mechanisms would also be extremely valuable. And then if they're successful, they may well be de-risked and moved into the private sector in the longer term.
So basically you want to invest in research.
I like research on all levels. Broad research, big science, and drug development, yes.
But broader research in terms of multiple disciplines.
Multiple disciplines, multiple people with very different perspectives. I think bringing people in with very different backgrounds, different ways of thinking about the problem are not only have a greater chance of transformative discovery, but also rejuvenates the people who've been in the field for a long time, because it forces them to think outside their usual trains of thought. And certainly as a scientist, the part that I enjoy most is working with people with really different backgrounds, with different ways of thinking about cancer.
It doesn't discourage you that for 50 years all kinds of people have been trying. It's not for lack of trying. 3.5 million papers is not lack of trying.
Certainly not for lack of trying. I don't know that the baseline assumption should necessarily be that after a certain number of years we should have a cure for cancer. It's a pretty challenging problem, and in the coming years, having a universal cure for cancer is probably too optimistic. But I think that the rate of change, both in terms of scientific understanding and in terms of new therapies, is extremely exciting and encouraging. And with the number of, a large percentage of all FDA approvals for new drugs are in cancer, and they may not be curative in most cases. They may shift survival without curing patients. But I do feel that if we have a larger and larger number of these new therapies, we'll be able to combine different types of therapies, immunotherapies, targeted therapies, non-selective therapies in clever ways that will really make a major dent in the disease.
Okay. Last question is a little bit philosophical.
Mm-hmm.
Offering patients with advanced incurable cancer
Mm-hmm.
therapies which are toxic
Mm-hmm.
and are not going to even prolong survival,
Mm-hmm.
get cured.
Mm-hmm.
Is that a service or a disservice?
Well, that last clause is obviously very important. There are many people who have an incurable cancer who can have enormous benefit from a therapy, both in terms of prolonging survival and in terms of quality of life. There are also many circumstances with an incurable cancer where the therapy may worsen quality of life and not be beneficial. It's not always possible to know that for sure in a particular patient, whether they'll benefit or not. So an important part of cancer research is predictive biomarkers, understanding who is most likely to respond so we can help guide those patient decisions. So ultimately, I think there's no question that patients who have access and advising about hospice and other therapies often benefit enormously from that. There's even studies in some specific circumstances where they even live longer by getting, palliative care rather than attempts at cure in a situation where that's not possible. So we shouldn't be afraid of offering those therapies, but it is such a deep philosophical question that I think patients are genuinely different in their philosophical approach to those problems. And so having a great oncologist who is able to articulate the goals of therapy, the potential benefits, the potential risks of therapy, and enable a patient to make those decisions. There may be some patients who are uncomfortable stopping at all and want to push forward almost no matter what, and other patients who are not like that and and want to choose palliative care, and neither are wrong answers. And so that's perhaps the art of oncology, and also where great doctor-patient relationships can be so beneficial. Thanks.